Beautiful. Live transcripts. Enable. Make my life easier a little bit later. Okay. So the intent of this is to be as much of a free-flowing, organic conversation as possible. That being said, I do have some scripted questions that I'll bring us back to or circle back to over the course of this next 45 minutes to an hour. So that should generally be the setup of it. So I'll get started. Thank you so much for agreeing to join me this morning. I really do appreciate you taking the time to spend this one-on-one with me. As you know, the aim of the interview is to hear more about your lived experiences within the domains of equity, diversity, and inclusivity. Your participation in this interview is voluntary, so if at any point you need to step away, pause, stop early, you want to skip through something, you let me know. You're absolutely welcome to do so. The interviews are recorded for the purposes of generating a transcript, so the recordings themselves won't get submitted anywhere, and the transcripts will be anonymized, so even if names or identifiers are stated, those will be removed after the fact. Do I have your consent to start?
You do.
Thank you. Before we get going, do you have any questions for me?
No questions.
Beautiful. So for the record, could you please state your age, your gender, and your role at the Cancer Center?
I'm 38 years old, male, and I'm a medical oncologist at the Cancer Center.
Fabulous. So question 1 starts by asking you to define or explain 3 terms in sequence, and so we'll go through those sequentially. So how would you define or explain to someone the term equity?
I'm already stumped. Equity. I think of equity as equal opportunity for all, regardless of someone's background.
Okay. So the idea that everyone is given the same means for an opportunity.
Sorry, the same
means for an opportunity?
Yeah, I think so.
All right, sounds good. And then how would you define or explain the term diversity?
Diversity to me refers to the varied backgrounds individuals have, whether it be cultural, whether it be in terms of other components of identity, sexual orientation, gender, ethnicity, and so on.
All right. And then lastly, how would you define or explain inclusivity or inclusion?
Well, inclusion I think of as being equally welcoming regardless of factors of someone's identity that as mentioned with the diversity definition, I think regardless of someone's background, being welcoming and inclusive.
All right. So keeping those themes and ideas in mind, do you see these domains playing a role or in any way influencing the patient-clinician interaction or relationship? And if so, in what ways?
So you're asking me, does equity, diversity, inclusivity, do these concepts influence the interaction between a patient and physician?
Mm-hmm.
It can. From the perspective of the clinician, there may be assumptions made or biases according to the clinician's identity in terms of someone's illness, their illness understanding, their values, how they make decisions about their health. I think the tendency would be to assume that people make decisions in the same way that the clinician does, and that may not always be the case. I think there could conversely be assumptions made by the clinician if they're aware of certain identifying factors, cultural or otherwise. The clinician may assume that the individual will make decisions or their values will align with someone's preconceptions about that cultural group. And that may not always be the case. From the patient's perspective, I mean, here I'm, I guess making assumptions in the way that I answer the question, but I'm imagining that it may be harder for some patients to be open and honest and to build rapport with their clinical team if they don't feel heard and understood. And if they feel that they're facing biases, that may be a barrier to engaging well with the clinical team.
For sure. So if it's okay with you, we'll explore some of those ideas a bit more, or I'll ask for examples. So I know that you mentioned that it goes both ways, right? A patient assuming certain things of their clinician when it comes to decision making, and vice versa. So from the patient level, for instance, what are some biases that a physician implicitly or explicitly may have, which could influence the care that they provide, that may worry a patient, right? That may fragment the trust that they have in their provider.
From the patient perspective, I mean, I think anything that would lead the patient to feel judged, I say that thinking of being judged as a negative feeling, a feeling that someone would want to avoid. And so if they feel that, details of their lifestyle, sexual orientation, employment status, and anything that would make them feel potentially judged, they may choose not to share that information. That may have relevance to their health or risk factors, and so that and anything that would, I guess, take away from open communication could be detrimental. And I think everybody's different in terms of what they'd be sensitive to, and what aspects of their identity would make them feel, potentially judged. Otherwise, I think an example that comes up is with patients that come with family members to their clinic encounters. There may be certain dynamics where either a family member is speaking over the patient or speaking on behalf of the patient, or there's a language barrier. And I guess we have certain values in, I guess, our conventional, say, Western approach to communication around health, that autonomy is important and that the patient should be in charge of the flow of information, and that may or may not be the patient's preference. That may or may not be their, the way that is their cultural norm. So I think we see that as a potential source of conflict when I think it's sometimes necessary to spend some time exploring how the flow of information works best for that patient and family, and potentially being a little bit flexible from our conventional approach. What else?
So I'll deep dive into that example a little bit further, if you will. So in those circumstances where, say, you have a patient coming in, but they're really, during the encounter, you're finding that the loved ones or the family or, whoever support person that they've brought with them is really taking center stage in the discussion and really sort of calling or leading the direction of that conversation. What are strategies or phrases or tools that you use to really explore what is underlying in that dynamic, and how do you sort of set yourself up for success, knowing that you have, based on your training and your perspectives, perhaps a worldview or bias about how this interaction should go?
What are strategies or phrases that I can,
or tools, or how do you even set up your thinking when you're encountering that?
I guess I want to start by exploring, in a sense, setting some expectations from the beginning, some shared understanding of how the information should flow. And so, in the circumstance where there's a language barrier, or circumstance where the patient is not voicing, but the family member is sort of leading the conversation, I would start not to sort of force disclosure of information that they may not want, but to say, my usual approach is to share all helpful information with the patient, the individual, but I'd like to start with some direction about what information does this patient want to know about their own health. What information would they rather not know, or to what extent do they want to assign a family member almost as a proxy, and kind of lay out some ground rules. And if I'm kind of given specific direction from the patient that, no, in fact, they don't want to be in charge of decision making, or they don't want to be fully informed about health, prognosis, so on, then I try to be respectful of that.
And how has that, I think, explicit opening of the dialogue been received by people? Like, has there ever been confusion or pushback, or has it always been very much taken, well and with openness?
I don't think I've personally experienced pushback. I think because it's not the most common scenario, but I've not had specific challenges with that.
Fair enough. And then earlier you had mentioned, as part of the way that these domains could influence the interaction is to the converse, where the patient perhaps is coming in with certain biases about their clinician, or the clinician's decision-making process. Do you have examples about that? Something that you've encountered or seen?
I guess that's assuming that I understand what's going through the patient's head all the time. I can't necessarily claim to know that. Much of this is what I'm assuming. Can I think of examples? Nothing's coming to mind.
No, that's fair. Because there is like the hypothetical risk of it, but if you've not encountered anything, that's completely valid. Have you?
I think this isn't exactly relevant. It's a bit of a different challenge, but I think mental health maybe comes up as such a situation where but again, it's like I don't really know from the patient's perspective how they've experienced bias. I think it's more from my perspective. I worry about someone with mental health challenge maybe not accessing care for other diagnoses in the same way as patients who don't suffer in that way. I think that's more a reflection of physician bias. So yeah, not really an answer to your question. Sorry.
That's fair. So just trying to tease that thread apart a little bit more, do you mean that there is a worry that they won't engage in having that discussion so that you can offer supports for their mental health? Or is it more that you worry that if someone is diagnosed or dealing with a mental health concern, that they will not get the same care as their counterparts who may not have those diagnoses?
More the latter.
Okay.
Yeah.
In what ways?
I mean, I guess, will they be sort of dismissed as poor candidates for treatment because of concern for compliance, or that, concern that informed consent is too challenging? Mm-hmm. There would be, I think, potentially complicating steps to get to a point of informed consent, and would, depending on the severity, may involve engaging with psychiatry, mm-hmm. engaging with ethics. The complexity of getting consent and pursuing treatment may lead people just to assess that patient as not a candidate, and maybe their outcomes from other diagnoses. Of course, I'm thinking of cancer, given that's what I do. Their cancer outcomes may be worse. I'm guessing that's sort of a hypothesis. And, thinking of the example of accessing palliative care for advanced or terminal cancers, much of palliative care happens in the community, and if someone has unstable housing or are maybe not reliable to answer phone calls and let a home care nurse into the home, there would be various barriers, logistical barriers, in terms of how community palliative care is delivered that would make it a lot harder for someone with mental health challenge, and could that potentially leave them suffering more than others?
Right. No, truly very valid. Now, in terms of other reflection of anecdotes, do you have an example in mind where you have borne witness to another person, whether it was a preceptor during your training, a colleague in your career now, or a learner that you've supervised, who has integrated these domains into the care of a patient, either very, very well, that stands out in your mind, or an example where it was done very poorly, that in reflection you're like, oof, that really could have been done better?
So as I'm reflecting about, trying to think of examples where something that relates to the aspects of diversity that we mentioned at the beginning, whether it's religion, sexual orientation, ethnicity, or cultural background. I'm not coming up with a specific example where I felt that domain was really brought to the forefront of clinical care or decision making,
Mm-hmm.
for better or for worse. Maybe it's just that we don't explore that enough, or maybe that shouldn't be the forefront of decision making. I think what I'm reflecting on is what we try to achieve in cancer care being values-based care, and that we ask people about their goals, their fears, their priorities, and we use the determinants of their quality of life to inform the treatment decisions. That's I think a standard that we strive for in oncology. And if someone's truly having open, fulsome communication about one's values,
Mm-hmm.
that conversation will be informed by the individual's background, whatever that background may be.
Mm-hmm.
So it's not that we're specifically saying, this is the cultural group that you belong to. So, I want to make sure that our decision reflects sensitively that cultural group. It's more, you're an individual.
Mm-hmm.
There's all kinds of stuff that makes you an individual.
Mm-hmm.
You have your own values. Tell me about that so that I can make sure that our treatment decisions align with whatever makes you an individual.
Mm-hmm.
I see lots of people doing that well.
Mm-hmm.
I think we're trying to encourage that to be more of a standard. And my favorite topic, the serious illness conversation guide. I mean, that's really what the foundation of that tool is, giving a structured approach to help clinicians learn to explore values in a more meaningful way.
Mm-hmm.
So could that potentially lead people to be more sensitive to factors of diversity? Maybe. I don't know for sure, but maybe.
And so what might be some barriers that would preclude, prevent, or hamper an oncologist, for instance, ability to do that, to explore that individuality, to explore that personhood with their patient?
Time constraints. So, when you're in a rush and you sort of come in with preconceptions and recommendations to make, and you prioritize talking through chemotherapy as the decision that's already made before you enter the room, rather than starting with an exploration of illness understanding and one's values that should inform the decision. So time constraint is a big one. And maybe, I don't know if inflexibility is the right word, but just sort of having standard patterns of care for certain diagnoses, sort of people fitting into boxes according to their diagnosis, and this is what we do. Mm-hmm. Again, that type of an approach to clinical care skips past the initial steps of illness understanding and exploration of values, mm-hmm. In order to get to the point of a values-based treatment decision.
For sure. Now, you yourself have commented that, your work with the serious illness conversation guide and a lot of what you've done really helps to explore that intent of having those conversations and exploring values and things that influence patients' decision-making process. In reflection of your career as a staff, and then also in your training, whether in your fellowship or residency, did you ever receive any formal training either in that or within specifically the domains of EDI?
Formal training. So I mean, I guess in oncology training, we have structured teaching and we have sort of teaching on the fly or unstructured teaching. And probably the bulk of learning in this area is clinical observation and feedback, so unstructured teaching. I think when I was in training, we had very limited formal training. I'm reflecting on our academic half-day curriculum or other types of retreats. With very limited formal communication training or this often gets lumped in with palliative care, but it really isn't palliative care. This is, universal across healthcare. I think of, in internal medicine, before going into oncology, I think we had a little bit more in terms of structured retreats, communication workshops, and so on, but it was still pretty limited. Mm-hmm. And then oncology, I think it was more about like observation and feedback, particularly on our palliative care rotation or on the ward, leading family meetings, and then getting feedback from preceptors.
And was it ever, in that observational feedback loop, specifically, instead of the more holistic, like this is how you communicated, did anyone ever carve out and it was just like, you did a very good job at exploring this person's lived experiences, their limitations in accessing care, like anything that could be ascribed as being more dedicated to EDI, as opposed to more broad strokes of like, you had very good communication skills?
Yeah, I think that would, nothing really could be called dedicated to EDI, as I recall.
And then in your time as a staff, especially since EDI has very much entered the zeitgeist and, the universities are very keen on integrating it, has there been any programming directed towards staff to enrich your learning or your skill sets?
So there was a very thoughtful Grand Rounds presentation that is the first example that comes to mind. Otherwise, honestly, I'm testing my memory. I think there were some self-learning modules that I did for HHS as sort of a mandatory workplace training exercise, I think.
Fair.
It was maybe a while ago.
And so, and have there been any pursuits in your own life personally, either through the professional lens where you wanted to shore up, or other times in your personal life where you had opportunities to engage in other training or engage in dialogue or attend seminars or anything as it related to this?
Nope, nothing comes to mind.
And so, I think there is a recognition presently in the time that we exist that this is something that we want to, have trainees learn about and integrate it into learning. But how would you see that done, knowing that there is presently no framework for that? And you said yourself, a lot of this is done experientially, but how do you homogenize that in training?
Well, I don't know. But I think you have to start somewhere. And I think, we do have, reflecting on our residency training program, we have a variety of structured curriculum. We have our academic half-day curriculum, which focuses more on sort of medical expert knowledge. We have a research curriculum. We have a wellness curriculum. There's all these different curricula. So I don't see why this couldn't be done in a structured way. Mm-hmm. How that learning is delivered, various options could be explored, whether it's, small group discussions, maybe informed by clinical examples that people have come across in their rotations or on the ward, sort of facilitated discussions, whether it's a lecture series, whether it's an electronic learning module curriculum with video examples, and then some surrounding content, trying to give people concrete tools that they can walk away with, that they can then incorporate into their kind of standard approach to speaking with patients, to show more sensitivity and to be more inclusive in their regular encounters. I don't know what would be the best format, but I think, again, there's no reason why it can't be structured as we structure everything else in our teaching, and we have to start somewhere.
I guess, especially with the current model of CBME, where a lot of residents' feedback is received in those like snapshots of encounters, obviously there is a need to equip clinicians as well who are observing preceptors. How would you target that group of people? Because obviously with learners, you can create a curricula and they have to attend because it's part of their curricula. But how do you target the people who are evaluating them on the other side so that they have the skill set to appropriately evaluate?
That's tough. Starting to get at, are the faculty appropriately trained and skilled themselves to even be educators in this way? And probably most are not. And physician change of behavior is very, very hard. So do you need kind of local champions to sort of take the lead, focusing on the learners so that the next generation will be better equipped to be sensitive to this in practice, and that in time that will kind of permeate, just sort of become a new standard in the culture of healthcare. I tend to think that that's the way change will happen. I reflect on not just this area of inclusivity, but also I think a lot about communication around end of life and wanting to improve in general quality of end of life care. I think the same applies, that the change of physician behavior is hard, and we can provide courses and learning modules, and we can really attempt to train our faculty and our current practicing clinicians. But a cultural shift, in my opinion, I think is going to have to start with learners who are going to be soon new into practice, and then they're going to move up to eventually be the educators. So I think it'll take time.
And so I think, speaking to your experience trying to especially disseminate those tools and I guess even encourage mindsets around end of life conversations, the work that you've been doing, how have you been able to motivate intrinsic buy-in from mid-career faculty? Because I feel like that is in my mind, a barrier that is hard to overcome.
There's no perfect way, but I think it's kind of an overlap of multiple factors. I think of one, needing administrative or institutional buy-in and support, and the messaging being that this is what we're striving for as the way we do things, the culture of our institution, that this isn't just one keen faculty member that's pushing their agenda. So administrative buy-in is one. Two, it would be kind of peer-to-peer coaching or nudging. There's different terms in the literature. But it's fine to do workshops for small groups or large groups, but then to really help change an individual's approach, having ongoing one-on-one support, I think is helpful, probably necessary. And what else? I think kind of regular messaging. So be it email communication or keeping this top of mind by having a grand rounds presentation, by updates at council meetings, like sort of regular messaging, so that this is relevant. That's I think necessary, so that it doesn't sort of cross people's minds once and then it escapes their attention and they never think about it again.
For sure.
So I think it's multifaceted.
Yeah. In asking you to do some self-reflection yourself, I mean, you commented on how these are not domains or strategies or conversations that are necessarily encouraged or taught in a formalized way during, your professional career or in your training, specifically in oncology and even to a very minor extent in internal medicine. So in reflection, when were you as an individual even made aware that these were domains that mattered? Maybe not with the same nomenclature labeling as we have now, with these perfect little terms, but when did you have a realization that these things impacted people?
I mean, I think it's been intrinsic throughout medical training, or arguably like throughout life, to be respectful of people regardless of their backgrounds. Was it formalized, or was it just sort of values that I carry with me as an individual? Hard to say. But I think there has been a shift in terms of messaging now. I think is more that this should be at the forefront. This should be a priority for an institution. This should be a cultural standard. And that wasn't always the case. It was more, let's be respectful of everybody and their differences. And, people could sort of adopt that or not. Whereas I think the current dialogue is that this is really high priority and this should be more formalized.
Yeah. I mean, to your point about, whether people should just grow up with a realization that, respect and acknowledgement of other people's life experiences should be innate. I mean, I feel like in a perfect world, yes. But other anecdotes that have been shared are people will say, I came from a very homogenous community growing up, and so no one talked about these things. Or it wasn't until I was exposed to a certain person or a certain encounter that I had to really reconcile with the fact that my lived experience was diametrically different than someone else's. And so I feel like, for some people there is that oh, this was the first time I had to like have reflection in myself that this mattered to others, or it mattered to me. And for some people, it's just, you're like you said, it's very much just as much a part of your life as anything else. So there is no aha, as it were. So when you think about it in yourself, how comfortable would you feel when engaging in these domains? Like, is this something that feels very natural and comfortable to you, or does it bring some anxiety? And whatever the answer may be, are there any learning curves or learning edges that you want to see yourself work on in the next, say, coming 5-10 years?
I mean, I guess what makes me uncomfortable, I mean, I think I generally feel comfortable with my approach to engage with somebody without judgment, and with kind of the assumption that everybody's different, and it's my job to try my best to understand their values, whatever their background may be. I think perhaps one obvious example of where I feel hesitant is religion. Comes up as an example where there may be strong religious influences on how someone makes decision around healthcare, end of life care, so on, and I don't feel fully educated. And so one is establishing if that's actually the case. Do they affiliate with a religious group where there are important learnings for me in order to understand how they want to make decisions? I probably need to get better at asking about that. And it would be helpful to have resources to turn to. I think the standard is kind of to say to an individual, do you have a spiritual leader that you turn to for advice on this matter? And can you ask them these questions, and can you let me know? It's sort of left on their shoulders. I don't have great places to turn when I have questions that relate to spiritual or religious affiliations. Mm-hmm. I think that's one area that I feel a bit uncomfortable, and I would like to work on that. I think I'm forgetting the second half of your question.
No, just in terms of like how you would describe your degree of comfort with these domains. And I think you alluded, and correct me if I'm wrong, that, it is something that you feel fairly comfortable integrating into the conversations and dialogues you engage in with your patients.
I think so, yeah.
And then the next question is more about your lived experience. So can you recollect a time that you were engaging with someone else, and they made perhaps assumptions about you, or didn't take the time to explore your personhood or your identities or your needs, and that affected you personally or professionally in a way that stands out in your mind? Or perhaps they made assumptions about you based on their initial judgment of meeting you, or what they assumed about you in knowing you, that was incorrect or unfair?
Nothing specific comes to mind other than, so on the one hand, I'm a white male, and so, that, I guess, limits my experience. I affiliate with Judaism, and I suppose that's one, I guess, minority group that, I have the experience of lived experience in that way. People will hear my name or look at my appearance and often be very forward in asking me about my religion. It's not uncommon, actually. And while I don't find that offensive, I find that delicate, because I don't know what they're thinking when they ask that. And I know there are biases out there that some people carry with them. And so it makes me a little bit uncomfortable in terms of acknowledging my identity when I don't know that person. And, how will that influence the way they think about our interaction? I suspect those that ask are, not going to bring any negative bias into the conversation, because clearly they're comfortable bringing that right to the forefront. But I do acknowledge that it makes me feel uneasy. And my preference is not to talk about my personal background with patients.
Yeah. Has that ever happened with like a colleague or someone within the broader department, where it's just been sort of put in front of your face apropos of nothing?
No. Other than some people really, really don't get that I don't celebrate Christmas, and they ask every year over and over again, what are the kids doing for Christmas? And anyway, I say that as a joke. Really, that doesn't bother me, but it is a lived experience.
No, fair enough, right? Again, it is sort of a normalization about what you do or don't do that is made about you with no exploration of your personhood, right? And it's a minor thing. It's like those easy things that you brush off and you don't think much of, but at the same time, it's like, it's an example, right? So the last question that I'll ask as we wrap up is there anything that we've not explored in this conversation that you want to discuss or have said as it relates to the primary research question, which is understanding how oncologists learn about and understand the domains of EDI?
Nothing comes to mind. I'm not sure if this is the thrust of your research, but as we talk about this and we think about education on a topic like this, one of the challenges that I anticipate is how do we do this in a truly meaningful or transformative way, as opposed to this being
a checkbox,
or kind of having like token representation of different groups. Just sort of doing this very superficially, I think, is a real risk. I don't have the answers to that, but I do reflect a little bit on that risk.
And so it's an interesting point that you raise, and one that, I've struggled with, because obviously every intent is for this to be a meaningful or organic, or at least authentic integration into learning, into teaching, right? Especially if there is a means by which that can be integrated into curricula. But there is a part of me that wonders, for an audience that has had none of the conversation, none of the training, none of the dialogue, is there still merit to tokenistic, superficial representation to at least get everyone to the same baseline? And I don't know. I don't know where that falls short or diminishes, and where it is still worthwhile. And I don't know if you have thoughts about that.
Again, you have to start somewhere, right? And I think really the question is, like, what's your end goal? And I think the danger of tokenism is that you sort of meet a minimum threshold and then you say, look what we've accomplished, we're done. And that's not good enough. So I think as long as it's seen really as only a place to start, to to demonstrate the importance, to keep it relevant, to keep it top of mind, I think it can be the first step as long as that's acknowledged.
That's all it is, and it's not the end goal unto itself. Yeah. Any other comments that you want on the record?
That I can think of.
Fair enough. So I'll pause the recording there.